So this is a presentation that Petra and I have done in partnership with a colleague of ours, Lauren Kundra. And we know Lauren is actually a participant in the webinar, but we likely won't be hearing from her today. And I've got to say that this is a topic that I've had the pleasure to talk with Petra and Lauren about for a number of years, really, about mental health issues, people with mental health issues and mental health agencies. And I'm really excited for us to have this webinar today, for us to have done the work that we've done and share it with you and really begin this dialogue with everybody. Our objectives today, and again, we hope to have this last about 30 to 40 minutes, and then we will likely leave around 15 minutes for us to answer your questions. But our primary objectives today are to briefly talk about why we need, or why I think we need to talk about creating welcoming work environments in mental health agencies. The second question we'll be addressing is, what are the experiences of non-peer specialist staff who have mental health issues in mental health agencies? And Petra, in particular, will be presenting some results from a survey that she did in partnership with Lauren as part of our center. And then I'll be briefly reviewing some recommendations that we've developed for creating welcoming work environments for employees who have mental health issues. So those are our three primary objectives today. I wanted to start off with some acknowledgments. The work that we'll be talking about today has been funded by a grant to the Temple University Rehabilitation Research and Training Center on Independent Living and Community Participation by the National Institute on Disability, Independent Living and Rehabilitation Research. As presenters, we'd like to thank Jared Pryor, who, again, you can send a chat to if you'd like, thanking him as well. Our colleagues, Jared, Rick Barron, Stephanie Wilson, and Katie Pizzichetti. And Petra and I and Lauren do not have any financial conflicts of interest or other disclosures to make regarding the contents of this presentation. So some background on why we're interested in talking about welcoming work environments in mental health. And I guess let me start off by briefly saying what I think about in terms of welcoming work environments. That's an environment where an individual feels safe and welcomed, safe and embraced and desired in that particular setting. You can talk about lots of different types of welcoming work environment, or lots of different types of welcoming environments. You can talk about welcoming work environments, welcoming educational environments like colleges and universities. These are things that we're interested in here in our center as well. You can talk about welcoming community centers, welcoming religious centers, lots of different settings. And again, the notion is that people, and in this case, we're talking about individuals with lived experience of mental health issues, that people feel safe and embraced and desired in that particular setting. So that's what we mean by that. One reason that we're interested in this topic is that there is a lot of research suggesting that mental health provider belief and attitudes about people with mental illnesses appear to be no different from the general population. And there have been two articles that have come out in the last 10 years or so. The references are given here and at the end of this presentation, and both of them have concluded that mental health care providers, their attitudes and beliefs about people with mental health issues do not differ from those of the general population, and in some cases are even more negative. And this leads us to be concerned about the experiences of people who are participants, people who are consumers of mental health services, and the kinds of messages that they get from mental health providers, as well as colleagues, both peer specialist colleagues and non-peer specialist colleagues in their interactions with their provider peers. So that's one concern that we have. A second concern is over the years, I've had a number of interactions with mental health providers in different agencies, and sometimes I'm surprised by the comments that these individuals make sometimes individuals in very high levels from different disciplines, not just one particular discipline, who say fairly negative things about their colleagues who have mental health issues, or that there's denial that there are colleagues with mental health issues, both in peer specialist positions and non-peer specialist positions. And these interactions have left me concerned about the experience of people with mental health issues who are working in these settings and how welcome they are, how free they're able to share their experiences with other people and really use those experiences in providing effective services to consumers of those agencies. I've also had interactions with individuals who run training programs for mental health providers, again, from different disciplines. I don't want to mention particular disciplines, and have had conversations where I've heard concerns about bringing students into academic programs where they might be providing mental health services, and concerns about an individual with a mental illness's ability to be a provider. And this also has raised a lot of concerns for me as well, in addition to concerns that it's a violation of their rights. So that's one set of anecdotes. And finally, I've heard concerns from colleagues who have mental health issues, again, both peer and non-peer, but non-peer in particular in this case, who have concerns about disclosing their mental health issues to their colleagues, and concerns that they won't be accepted or welcomed, and that they may even be treated poorly by their colleagues. And the bottom line here is that by not fully embracing individuals with mental health issues as colleagues, as providers in the mental health system, we might be missing out on valuable experiential knowledge in non-peer support clinical services. So it's not just peer support where this can be valuable, it's also non-peer support clinical services. And my colleague Petra Kotziefer has written a very nice article describing some of the things, some of the valuable experiences that can be contributed. The other major reason why I'm interested in this area as well is some of you know that I've been working in the peer support area for a number of years, and I'm very interested in the peer workforce and their experience as colleagues in the mental health system in various roles, important roles that they play. And I've documented, and other people have documented, that there are challenges regarding the effective incorporation of the peer workforce in the mental health system. Some of these challenges are related to being brought into environments that may or may not be very welcoming of experiential knowledge of having a mental health issue, that there might even be perceptions that of harms associated with this experiential knowledge and interactions with consumers within the agency. And my bottom line concern is that if the non-peer workforce, those individuals who are non-peer roles and disciplines, such as psychiatrists, psychologists, social workers, other individuals who aren't necessarily in peer support roles, if those individuals are not accepted and embraced in a mental health system and a particular agency, then I think it's probably safe to presume that the peer workforce will not be accepted and embraced as well. So we really need to create a welcoming work environment for everyone, peer and non-peer, people in peer and non-peer roles who have experiences with mental health issues. So now I'm going to turn it over to the survey by Petra and Lauren.
Hi, everybody. So we're switching seats here. Mark projects really nicely. Ouch! I hope I can match this somewhat, and I hope you guys can hear me. I just wanted to tell you very briefly that what I'm about to present to you, we're thinking of a little bit as a pilot data project at this point. It is also part of a larger data set. We're actually interested in sort of behavioral health professionals and self-disclosure of mental health issues sort of more broadly. So we actually also had peers respond in the survey, and we also had folks respond who did not self-identify as having any kind of mental health concern. but I am not presenting to you on that data today. So I'm just presenting to you data from our survey that is specifically from individuals like myself who work in professional roles and who have either in the past or still are currently experiencing some kind of mental health concern while they're working in the setting, and who may either have disclosed or have not disclosed. And my personal interest in this topic obviously arose out of my personal experiences, and I would say that is the same for Lauren, if I may speak for her. And I couldn't sort of agree more strongly with Mark, with regard to the strange experiences I've had when I have at times disclosed to other individuals, and I've had reactions that I absolutely did not expect from individuals who were in professional situations, as well as very supportive reactions from some other people. So you will see some of this reflected in our data as well. So let me go right to that. So again, we wanted to find out what exactly is out there in terms of folks that say that they have mental health problems. There are some surveys in the literature, a lot of them are from the United Kingdom actually, that sort of try and look at how many people actually work in the general workforce that have mental health issues, including the quote-unquote more serious mental illnesses like schizophrenia, bipolar disorder, or serious depression, or borderline personality disorders. But sort of reliable data on disclosure experiences doesn't really exist. I think this is just sort of an up-and-coming area of interest. Disclosure seems to be even rarer, or rather data on disclosure is even rarer on employees that work in behavioral health agencies. And some theories behind that Mark already mentioned as well, and that is there is unfortunately still a very strong us versus them climate in some provider agencies, and there are obviously many reasons as to why that occurs. But becoming one of them might blur the line for people, and it's very uncomfortable, that being one of the reasons. And so we were specifically interested in this round of what happens when individuals disclose where they work with other individuals that provide services for people with mental health problems. And again, the last point Mark already made in his comments at the beginning of the presentation, and that is, as providers, given that I'm one myself, it is unfortunate that people still hold largely negative beliefs, more so about people with psychotic disorders, probably bipolar disorders and borderline personality disorder, and that is very similar to the general population and attitudes on serious mental illnesses in the general population. Attitudes towards depression and anxiety disorders have changed somewhat over the last 10 years, but they have remained largely unchanged for some of these other disorders. So quickly about our sample. So we were left, after we excluded the other individuals, with 69 respondents that self-identified as having a mental health concern, or more than one mental health concern, who worked in some kind of behavioral health setting. Our sample was largely female, 42 respondents, and again, we solicited respondents, so these were individuals that responded to email invitations that came through the collaborative mail-outs, but we also did a lot of snowball emailing through to other channels and social media sites. But we ended up with 42 women, 7 males. We had about 20 people that didn't get to the end of the survey, where they didn't fill out their demographic information. So we don't know what their gender were. We had a largely Caucasian sample. 43 people identified as white or Caucasian, and only very few minorities participated in the survey. So we obviously hope in the future to do more surveys like this and have a more representative sample. The age of the sample was around 40-some years, with a pretty wide standard deviation. I think the youngest participant was about 20 years of age, or 21, and the oldest participant was 65. 64 people of the 69 said that they have had outpatient treatment in the past, and 44 were receiving it currently. 42 individuals said that they were currently on medications for some kind of psychiatric concern. About 30 of those 69 people have had inpatient hospitalizations. And again, there was actually a very wide range there, with a bunch of people having 1, 2, or 3 hospitalizations and a few people having 10, 11, 12, 20 some hospitalizations. The mean of those folks that were hospitalized was 4.6 hospitalizations. Who did we have? We had no psychiatrists respond, which was really sad. We also hope that that will change in the future. I'm also sad that as a psychologist, we only have 2 psychologists respond. We had 1 RN that's specifically identified as a psychiatric nurse. 27 mental health professionals. Those folks were people with LPC, social work folks, marriage and family counseling, etc. 1 DNA counselor, 5 case managers, and then we had 3 allied health professionals and 5 other were largely management folks, some agency directors, etc., etc. As you can see, the majority of the sample also reported having kind of anxiety, PTSD, OCD type issues, and major depression. 15 individuals had bipolar disorder. 6 individuals reported having borderline personality disorder, and then there was a variety of other disorders. Numerous people indicated that they had more than one problem. There was 1 individual that identified as having either schizophrenia and or some type of other psychotic illness. So you have to keep this data in mind as we're going through some of the next slides. Again, I don't think this is necessarily a largely representative sample, but it gives us some first good impressions, I think, and maybe also some misleading impressions. So how many of those folks actually have disclosed at the workplace? And that surprised me. 50 of the 69 people, and everybody answered this question, said that they did. And here's who they disclosed to. They disclosed to coworkers. That was 38 people said, yep, they had disclosed to coworkers, and 34 people said that they had disclosed to a supervisor. Only 15 people said that they had disclosed to their HR department. Again, the same person could have indicated that they reported, yes, that they disclosed to coworkers and a supervisor. So these are multiple responses from the same person. That's why that doesn't add up across the categories, right? So 50 people disclosed. I found that somewhat surprising, actually. The disclosure experiences also surprised me a little bit, were largely positive. About 17 people said that their disclosure to their coworkers was positive. However, given that here the sample size gets a little bit smaller because not everybody answered all of these questions, 7 people also said that they had a really negative experience. And given this is a relatively small sample, that's still a reasonable amount of people that had a bad experience. 8 people had a very bad experience with their supervisor. 20 people, however, had a good experience. And again, for HR, where you, in theory, shouldn't have a bad experience, 3 people had a bad experience, 4 people had a neutral experience, 7 people had a positive experience, right? 6 people said they didn't disclose to that department. So that's how that kind of shook out. Kind of interesting. So definitely a little bit more positive than I expected. Again, keep in mind who is represented by the sample, what illnesses they may or may have not disclosed, et cetera, et cetera. So we asked folks tons of questions in the survey. We probably asked them slightly too many questions. So I'm just going to give you a brief overview of some of the things we asked. So we asked them, why did you disclose? What were the benefits of disclosure, right? Besides like maybe getting an accommodation or something. We asked, did you feel sort of supported after you disclosed? And 27 people said, yep, they felt supported by their coworkers. 24 people said they were supported by their supervisors. Really interestingly, mutual disclosure occurred for 24 people with their coworkers, but not their supervisors. So after they said they had some kind of issue, whatever that may have been for that specific person, apparently there was some type of reciprocal disclosure from this individual's coworker. that's very fascinating, and I'd love to know more about this in the future. Apparently, 9 supervisors gave a mutual reciprocal disclosure of something. Not surprisingly, that didn't occur in the HR department. Accommodations were sought and discussed by very few people in the sample, and I'm going to talk a little bit more about that later. Normalization is one of the biggest benefits that was endorsed in terms of being able to quote-unquote come out to their coworker. Again, so for somebody like me who has experienced some problems in the past, it was also extremely important to be able to tell the people that I was working with what was going on with me, because the cost of hiding seemed so high that the normalization that I experienced from being able to say what was going on with me and receiving support was vastly important. And you probably know, or maybe you don't know, that in the literature this has been written about very similar to the coming out process of individuals who are maybe gay or lesbian. So these are at times, quote unquote, hidden identities, and hiding them and continuously hiding them can come at a cost. It can come at a cost to your health, to your mental health, to your work performance, et cetera, et cetera. So that wasn't surprising to me to see normalization as really important benefit to individuals. A lot of people also said it gave them an opportunity to address stigma within their own agency, and that was something we brought up earlier. I can't tell you enough, and I'm sure some of you guys have had this experience. You're sitting around in a treatment team or wherever you are, and people are making, at times harmless comments because they come out of frustration, whatever, about clients, but at times comments that are very disparaging and very stigmatizing. And you are sitting there and sort of thinking, wow, this is really interesting. So it didn't apparently occur to you that one of us might have been or might fall into the same diagnostic category than the person that you're talking about. So combating stigma was something that several people noted was a benefit. And then 4 people said that they experienced or had no benefit from their disclosure. So we also were then interested in asking, obviously, were there any problems that you experienced as part of your disclosure? And that, of course, only applies to the people that actually said that they disclosed. So the N here is still kind of 50. And I'm going to read you at the bottom now, because not all of that was able to print. So 2 people had fear of job loss that occurred after they apparently had disclosed. 6 people said that they either experienced or were very afraid of a loss of responsibility. Negative impact on possible promotion was another category that was endorsed by 5 people. Having sort of social distancing, right? Being avoided, being looked at differently, that apparently occurred to 4 people that had disclosed. That is definitely something that once happened to me as well. It's very interesting because, God forbid you disclose that you have depression, or God forbid you disclose actually you have bipolar disorder, and then you're having an especially exuberant or happy day, and before you know it, you're in a manic episode, which you possibly are not. You're just in a good mood. But there's definitely the fear that you are then being seen through that lens by your coworkers of that person with a mental illness. And I've heard this actually from several people that have disclosed that have had similar experiences. 7 people said that the person who they disclosed to needed a lot more education, specifically about the psychiatric illness or condition or problem that they had actually disclosed. 4 people said that their information was shared with other people against their will, so sort of gossiping kind of stuff. And then 8 people said that all sorts of miscommunication occurred after they had disclosed that somehow affected their job. And then 28 people said that they experienced no significant problems as a result of their disclosure, which that's actually encouraging to see. Of the 43 people that answered the question, if you regretted your disclosure, 4 people said that they absolutely did. And 1 person lost their job. Other people reported that they had received microaggression or that they felt harassed or bullied. And again, 4 people out of 50 people is not a vast number, but it's almost 10%. And of course, that's unfortunate that occurred to those individuals. So then we asked people how much they knew about accommodations that might exist for their varied conditions. And that looks like what we know from grad school or from any kind of school. If we've ever taken a stats class like the normal bell curve. And I would say there's definitely room for improvement for knowledge. The majority of people said they were moderately familiar with accommodation, but there still appears to be quite a need for education. A lot of agencies still don't even seem to be really familiar with the idea that as somebody with a mental health issue, you can request accommodations. And then what those accommodations could possibly be is the next thing that sort of perplexes folks. 15 people, and then only 3 people of this entire sample said that they had actually requested accommodations at their current job. And 15 people said that they did not request them because they did not need them. And that was interesting, and there was a variety of responses there. A bunch of people actually said they didn't ask for them for a variety of reasons. They didn't know whom, they didn't know how, they were afraid of retaliation or some kind of negative impact, on their position or promotional opportunities. And some other people said that they, of course, didn't need them currently, which would be the same case for me. I mean, some mental health issues are episodic, and you may not need accommodations if you are not in some kind of acute episode of whatever it is that you are dealing with. So why did respondents not disclose? So we asked those 19 people in our sample that had said that they didn't disclose, why they didn't disclose, and this is what they said. One person said they had a promotion concern. 11 people, like I just said, were very worried that as a result of their disclosure, they would be either viewed personally or their work would be viewed differently as a result of their disclosure. So competence questions, right, that are often raised for individuals with mental health concerns, even if people are not in an acute episode of their illness. So distancing was a concern that 2 people had. My info being shared with others. 8 folks were concerned about that. 10 people said it's nobody else's business. That's why I didn't disclose, and obviously I didn't need accommodations. Organizational culture or climate, not having a climate where you're welcomed as somebody with a mental health problem in a professional position was endorsed by 3 people. It's not relevant to my current situation was 12 people, and 5 people gave a variety of other reasons. We did ask folks what they thought would help them to make their disclosure decisions. So what could organizations do specifically to aid this type of disclosure? Folks said that they would disclose when they felt it to be appropriate and thought it would be beneficial to another person, a coworker, or even a client. They felt if other folks had a better understanding of what mental health issues were, that would ease their disclosure, which is a little bit shocking because you're working in the mental health field and you would expect an answer like this. Sorry about this. You would expect an answer like this maybe from another type of employer. But here folks were also saying that apparently some of their coworkers didn't seem to have a very good understanding of, experientially at least, what folks were going through with some mental health issues. They would be more likely to disclose if that information would actually be kept confidential, if the person was asked to do that. If they felt their position or reputation would not be threatened as a result of the disclosure. Some people said they would only ever disclose if they were legally required to disclose, such as for licensure, which one person wrote about actually as that having been a huge problem for them, if they needed accommodations, or if they thought that they needed some assistance because their mental health conditions were impacting their actual work performance. So what can you do as a provider agency to make folks feel more at ease with disclosing? One of the biggest themes that sort of came out of that was to address workplace culture, right? In a sense, it's kind of like, well, we have a sort of recovery transformation going on in the United States, and we talk a lot about recovery and recovery-oriented environments, but we don't talk about that for the staff. We talk about that for our clients. So folks pretty much were saying, well, hey, you know, it would be great if this would also be the case for us. If we could work somewhere where wellness and inclusion and being able to be somewhat more open about these things would be welcomed. So folks said that would be helpful to them to post or publish policies regarding disclosure and accommodation. They said an agency could be more supportive by having supervisors trained and having them be supportive and interactive with their own staff. Have agencies really work on wellness initiatives, not just for their clients, but also for their staff. And just address the topic just to begin with. There are folks that work in professional positions that have had experiences with substance abuse, with cancer, with mental health issues, with diabetes, and just talk about these things more openly with regard to mental health issues, just as we do today about cancer, which we also didn't do in the 50s. Folks suggested that agencies could have an awareness day to really change language practices, right? And change these ideas of us versus them, the clients versus us, the staff. More information about mental health issues in the workplace, non-judgmental communication, not practicing stigma themselves, going back to some of the points that Mark was addressing earlier on. Create welcoming spaces and maybe even some practices or specific activities so that staff can decompress. Be aware of language and the power of language, which I already said, which goes back to being non-judgmental, and also be explicit about the value of lived experience. And just as an anecdote, the other day, as I'm on a unit, merrily going about my business, I overhear a group being run by a mental health tech, a morning group where they basically just do the community meeting, as that tech is launching into his own experiences with his own depression, which is not something you hear very often, actually, where I work, or really where I've ever worked, and in the most compassionate terms was trying to sort of motivate the client community that was assembled there in the morning. And I pulled him apart later and talked to him about this, and sort of just had an interesting conversation with him about this. And I saw the clients be fairly riveted. I mean, mind you, that might just be because it was a very unusual experience, but they definitely responded to that individual in a different way. So those were some of the things. Here were some of the self-disclosure trainings that folks thought could be provided. Folks wanted more about, the one that was most requested, as you can see here, 39 respondents said they wanted more information on the ADA, followed by, hey, how do we deal with functional limitations and stress as somebody with a mental health issue, followed by lectures or seminars or workshops on professionals in recovery. How many are there? When is our competency maybe threatened, which at times may actually occur, and how can we take a week off? You know, how can we call out and say, hey, I need a week off, or I have to go to the hospital, or X, Y, and Z. And conversations about risks, boundaries, and ethics as well, and you can see the others there for yourself. So those were some of our findings. I hope that gives you some idea about what folks are dealing with, and I'm going to turn this back over to Mark.
All right, thank you, Petra. First of all, I see, remember that you can enter your questions or comments. Questions can go in the Q&A screen. You can just type them in down there and then click send. And you can also chat with other people during the talk. And I see we have one comment or one question from somebody. Can we get a reference list that provides citations for the articles the presenters reference on the slides? And there actually is a slide at the very end of this presentation that lists all the references We will be able to get these slides to you. I think we'll be emailing them out to everybody, but if you want them sooner than that, you can send me an email at msalzer@temple.edu. I just put that in the chat box, so you can see my email address. You can write me directly. So I wanted to thank Petra and Lauren for doing that survey. Very informative. Really, we believe it's probably one of the first, if not the first, pilot survey on this particular topic that we think is important. There are some findings that we were surprised by, some that were really confirmed some of the things that we were thinking about as well. So it's really a very exciting area. What we've done in partnership with this survey is I worked with a colleague, Laura Welder, who is with us here at the Temple University Rehabilitation Research and Training Center, and we also call ourselves the Temple University Collaborative on Community Inclusion of Adults with Psychiatric Disabilities, to develop a document where we provide recommendations for fully embracing and supporting clinical staff with mental illnesses. And you can see that here. This is the cover. You can also see the website where this is located. Another thing you could do is just go to Google, type in Temple University creating welcoming mental health work environments or something like that, and it'll pop up. What I wanted to do is very briefly go through some of the recommendations that we came up with. And again, these are just suggestions, things for you and your organizations to be thinking about that you can do that we think would be positive contributions to creating a welcoming work environment for everyone, really. And the first one is creating a vision statement. And basically, this is a vision statement where the agency articulates that we are an agency that supports everybody who experiences disabilities, who's people with differences, and specifically mentioning staff, both in peer roles and those in non-peer roles who are here. And having this statement being that you are welcome here. We will do what we can to provide a great work environment for you. This is actually based on something we did, we funded with Bazelon Center for Mental Health and the Law. They created a model policy for colleges and universities, statements that they would make saying that they welcome and embrace college students with mental health issues. This is something that could really be a model for an agency to use, and I'd be happy to help put you in contact with that document as well. So the first thing you could do is create a vision statement. A second thing, set of things you could do is a number of activities related to strengthening the foundation of the work environment. The first thing is to develop a better understanding of what are the issues in your agency. You could conduct a staff survey asking about people's experience themselves with mental health issues. What are their experiences? What types of diagnoses? What types of medications maybe? Just to get a sense of who's working in your agency and what experiences and value and uniqueness they bring to your agency. So the idea here isn't to do a deficit-oriented survey or something like that. It's to find out what are the uniquenesses and skills that are present here. There could be focus groups or key informant consultations with people asking about experiences, what's going on in the agency, is this an issue here, as well as conducting a risk assessment. Are there specific programs that are being offered that generate a high degree of distress for all staff, let alone individuals with mental health issues? And this could exacerbate pre-existing issues or just create general distress for any employee that could also lead to burnout. So just developing an understanding of what's going on in your agency could be important. The other thing is making sure your agency is providing the basic mental health supports for their staff, that be it the health plan, looking at pharmacy benefits to make sure it's appropriate, and obviously making sure that you have an employee assistance program and that your staff know about it and are encouraged to use it. That can be an amazing resource for people, again, for people who have experience with being diagnosed and those who haven't been diagnosed but are experiencing some type of mental health distress. That can be very valuable. Another set of strategies have to do with creating more welcoming, these are welcoming strategies, we're calling them. The first is developing a wellness committee. We spend a lot of time, thankfully, talking about wellness for people that we work with in agencies and services. Why not talk about creating wellness initiatives for all the staff, including talking about mental health wellness, not just have it be about smoking or weight loss or cardiovascular activity. Let's talk about the stress that all of us feel at times in our work environment, and how can you create a better environment. There are some recommendations in here for human resources staff in particular, helping them as they onboard people into agencies, making sure that they're aware of mental health issues and are discussing accommodations and other information about all disabilities or all issues or impairments, but also mental health issues, and doing it in a way that's welcoming and encouraging and not necessarily discriminatory or assuming that people don't have issues in those areas. You could have policies, written policies saying that mental health issues or other impairments won't be attended to or thought about when making promotion decisions or when making termination decisions. And also talking about sick leave and disability leave, and I think Petra made reference to this, making sure that people know that it applies not only to physical health issues, but mental health issues as well, and both are incredibly important to all of us. Another set of strategies are creating an open atmosphere where people can talk about mental health issues and do it in a way where there isn't a tremendous amount of fear and discrimination that people have concerns about. Ensuring that people are aware of the reasonable accommodations. Those are some important results that Petra and Lauren found, and we found them in other research that we've been involved with, that people in different settings aren't aware of the accommodations and their rights being in those environments, and that's incredibly important. There really is a need to obviously maintain confidentiality when somebody does disclose, so there really shouldn't be this gossiping, and I think some of the preliminary data that Petra and Lauren obtained suggests that that doesn't happen very often, but it certainly is something that we should all be sensitive to, that maintaining confidentiality is important. Practices and programs that can be implemented. There could be specific training for supervisors around distress in general among staff that are working in various programs, including being sensitive to mental health issues that people might experience and how we can help support those individuals and what kind of conversations are appropriate to have. In some ways, it's almost thinking about mental health first aid within the mental health agency itself. To make sure that people feel safe and secure and there's an appropriate response. Making sure that people are sensitive to communications, like Petra was talking about, that we don't talk about people with mental health issues that we're working with in derogatory ways, because the colleague that you're talking with may have a personal experience, or their family member, or their spouse, or their son and daughter. And we all need to be sensitive to these kinds of things. Creating opportunities for staff to collaborate on various activities that, again, promote wellness and support of one another. So within the peer specialist movement and peer specialist workforce, there's a lot of conversation about peer staff, people who are in peer roles, gathering together and talking about their experiences working within agencies and programs. There's no reason why all staff can't come together and do that and really support one another. Peer support is applicable in a lot of different types of settings. So there are a number of different things that could be done in an agency to create a welcoming environment. I would encourage you to take a look at this document. It doesn't provide thorough details on how to implement each of these recommendations, partly because Laura and I recognize that each setting is different. and we couldn't possibly, say everything that you could do to make this happen. But we encourage you to take a look at it and think about it. Here are the references that we have for this presentation, and again, we're happy to send this PowerPoint to you, and maybe even help you receive some of these documents as well. So we do have a couple of questions. So let me go through them now. We have a question from Larry Russock. Is there any pushback to the peer professional term? For instance, as a person with a mental health diagnosis, are they just always destined to be peers and nothing else? So I talk about my observations and my experience with the term. The first thing is a lot of people are using lots of different terms for the roles that peer specialists are in. I've heard some people say that they don't like the peer professional term because it outs them automatically with everybody else that they come in contact with, and they don't have control, I guess, over their disclosure. They don't control who they disclose to or who they don't, because it's the name of their role. And I know other people who fully embrace it and don't have those concerns. So I would say that there's a lot of different reactions to that term. The other part of your question is, and I think this is the second part, is are they always destined to be peers and nothing else? And I don't know if this is a comment on career ladders or not. If people who work in peer roles, some actually have gone on to get additional training. I know people who become social workers who have gotten their MSWs and work in other non-peer professional roles within mental health agencies. So people are doing a lot of different things and hopefully maintaining their peerness, even in those new roles as therapists or case managers or other types of things. But there is a general concern about career ladders for peers. Petra, do you have anything?
No, just for folks who are professionals and traditional roles with mental health issues, Fred Fries has coined the term quote-unquote prosumer. Again, that's sort of a professional and consumer, not a professional consumer. And I think it depends, right? It depends on what you're kind of thinking your role is in an agency. I could see myself using that term sometimes when I think I want to be more of an advocate and I want to change things and I want to combat stigma. I can also understand the folks that answered our survey that kind of said, well, I don't think it's relevant. I'm not having any issues right now. Why should I disclose that? Just as well as maybe you want to not disclose the fact that you have cancer. It might be something that's very private to you, and I think we differ on that as individuals. I think I at times fall a little bit more on the disclosure, into the disclosure realm, especially if I think that we have a role to play there in combating stigma. But that's my personal opinion. So.
And we have some comments that are related to what we're just talking about. Stacy, thank you for sharing your experience with the title Peer Whole Health Coach, and some concerns that there's some stigma to the title peer. And I definitely understand that. And it's not always clear to me whether or not peer needs to be in the title of job descriptions or not. And I do know people differ about that issue, but thank you for sharing. Lisa writes, how can leaders, supervisors, well, actually I can put it on this main screen over here. How can leaders, supervisors balance being supportive and open with not pushing people to disclose? I think supervisors at some organizations are worried they may be in touchy legal territory. That is correct. First of all, we're not giving any legal advice here or human resources advice. You definitely need to talk to people within your organizations. As a department chair here at Temple University, I am very cautious about how I talk to people who work with me, faculty, but also students. We talk about our interactions with students, that we do need to be careful about our comments, but we can also still be open and create a welcoming environment so people feel comfortable in sharing whatever they want to share. But the primary thing is I do not probe. I do not make suggestions. I do not say it seems that you're depressed or anxious. I don't label. I don't do things like that. And we certainly also can't push people to disclose, but we can certainly say, just letting you know about the resources we have available here. If there's anything I can do, we don't say you need to go get them or whatever, because people do have choice. They have control over their disclosure. So you're absolutely right, and all of us should really be aware of our agency's policies and practices regarding this. But there's a difference between creating a welcoming environment that allows people to comfortably disclose and forcing people to disclose.
Yeah, so again, I think I would add on a very concrete level, if your agency has a workshop on individuals in recovery at your own agency or something, right? The Rent-Free Center, which is a specific eating disorder place, once did something very interesting. Actually, I think here in Philadelphia, where a bunch of people who worked in management positions actually kind of came out to each other at first and then said, well, how can we use this to the benefit of our organization? And they did a workshop for their own staff, not just on their own experiences, but on how their own experiences sort of affected their work and how they saw their professional roles. That's, of course, an extreme example. There are many supervisors that do not have lived experience, and that's okay. I think I sometimes just say to folks, I supervise a lot of students, and I'm just, again, like Mark, I don't probe, but I say, are you okay? You can talk to me, you can talk to other people, there are other folks I can send you to. It's a safe environment. I remember there was research initiatives at the universities going on, in the old days where there were stickers for domestic violence, safe zones that exist with mental health now. So maybe that's something we need to have at our HR departments, or maybe there needs to be a wellness person hired at an organization that can be on site and not just some weird, employee assistance person. Maybe just somebody who you can talk to confidentially, that's part-time at an organization. So I think there's lots of different options, and we're just sort of starting to grapple with what some of they are. But organizational culture is a big one, I think.
So one last question appears that we have, and I'm aware of the time and don't want to take us over, but do you have to disclose your mental health status?
No.
And the answer is absolutely not. And in some cases, as we saw from some of the data that Petra presented, some people have very good concerns about not disclosing. It's not illegal to not disclose. There are some benefits, but there are definitely some downsides to disclosure. And the idea here, I think, that we're trying to communicate is creating a work environment and strategies and policies where people feel even more comfortable to disclose if they want to, where they feel like the environment will support them and they'll get what they need to be even more effective employees and more effective staff. So no, you do not have to disclose your mental health status. So I've got 2:59 Eastern Time. We didn't want to keep you longer than an hour. We appreciate, we had about 99 people at one point. So we're thankful for your interest. Please send us any questions or comments you might have to both of us. And again, we hope to be able to get you this PowerPoint. If you or your organization is interested in are talking with you further about these issues, please just feel free to contact us. All right. Thank you very much.
Thanks
Everybody
so much.
has a great rest of the day.
Thanks, guys. Bye.